Editors. In the past few years, wearable tracking devices have become commonplace in the United States. These devices enable users to count steps, track calories burned and miles covered, be reminded when they have been sitting too long, share data with others, and examine trends over time. More and more, consumers have accessible tools to assess their own health behaviors and health risks in ways that once were available only through health providers. For example, researchers at the Massachusetts Institute of Technology have produced sensor-infused bands that send alerts when a person may be about to suffer an epileptic seizure, Poe et al., 2012. This is an example of how the frontiers of communication and behavior have expanded far beyond what we imagined 25 years ago, when we wrote the first edition of this book. It is an exciting time to contemplate behavior change. Perhaps never before have there been so many demands on those who aim to facilitate positive changes in health. Behaviors and so many potential strategies from which to choose. Whether it is the need to reduce the rate of hospital readmissions in order to avoid costly penalties from Medicare or communities faced with increased rates of childhood obesity, there is growing recognition that health behavior changes are needed across the world if population health is to improve. Where professionals once might have seen their roles as working at a particular level of intervention, such as changing organizational or individual health behaviors, or employing a specific type of behavior change strategy, such as group interventions or individual counseling, we now realize that multiple glands, K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 4. For Chapter 1, the scope of health behavior. Kinds of interventions at different levels often are needed to initiate and sustain behavior change effectively. Once, health behavior experts might have relied on intuition, experience, and their knowledge of the literature. Increasingly, however, professionals are expected to act on the basis of evidence. In the time since the first edition of this book in 1990, the evidence base for health behavior change has grown dramatically. Along with the evidence base on behavior change interventions is growing interest in using and assessing the impact of theories of behavior change. Many systematic reviews have examined whether using theory in crafting interventions can lead to more powerful effects than interventions developed without theory. Lands and Bishop, 2010, Michie, West, Campbell, Brown, and Gainforth, 2014. Reviews have varied in how they code theory use and specific theories, and how they interpret findings related to the theory use impact question. Some reviews found that using theoretical foundations for interventions was associated with better outcomes. Albada, Ozzums, Bensing, and Van Dulman, 2009, Ammerman, Lindquist, Lohr, and Hersey, 2002, Legler et al., 2002, Knorr, Bennick, and Harris, 2007, Knorr, Black, and Pierce, 2009, Taylor, Connor, and Lawton, 2011. Some reviews found no association or mixed results. Gardner, Wardle, Poston, and Croker, 2011, Prestwich et al., 2013. As the body of literature of systematic reviews and meta-analyses of interventions that examine theory use grows, the picture becomes more complex. Our interpretation from a review of reviews to date suggests that outcomes are better when theory is applied or more thoroughly applied. But this is not a simple, strong, or unequivocal conclusion. Nonetheless, there are many reasons for both researchers and practitioners to be well-versed in the theoretical foundations of health behavior and facile with applying them in their work. It is even more important to become skilled at using and testing theories, because some equivocal results may be due to failures in theory specification and testing. Today we have many tools and strategies for improving our understanding of the role that health behavior theories can play in producing effective, sustained behavior changes. These tools and strategies are more and more accessible from web-based repositories. Furthermore, the stage for health behavior change research and practice has changed from one that was primarily local and country-specific to one that is both global and local, in a world that is increasingly interconnected. These exciting opportunities are occurring at a propitious time. The positive and rapid changes in medical innovations, a strong evidence base, and increasingly accessible tools for health promotion are buffeted by countercurrents of increasing globalization, urbanization, industrialization, and inequalities that may deter us from fulfilling the promise of advances in medicine and health promotion. Major challenges include the billions of dollars spent yearly across the world on the promotion of unhealthy lifestyles, such as tobacco use and sugary beverage consumption, and also the challenges of physical inactivity, increasing pollution, and health problems associated with poverty, including overcrowding, lack of safe drinking water, unsafe neighborhoods, and limited access to healthcare. Unhealthy behaviors continue to account for a disproportionate share of deaths in countries around the world. And the rise of non-communicable diseases globally is a major threat to glands. K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 5. Chapter 1, The Scope of Health Behavior 5. World Health, Pushing Many Below the Poverty Line, Choi, 2012, Ludi, 2015. National and global health policies must encourage and enable people to practice healthy habits, Ludi, 2015. Improved health is not dependent on medicine or healthcare alone. It is the sum of multiple factors at multiple levels of societies. The topics on which health professionals and health behavior specialists focus have grown and evolved as health problems have changed around the world. Fisher et al., 2011. Professionals may counsel people at risk for AIDS about safe sex, help children avoid tobacco, alcohol, and drugs, assist adults to stop smoking, teach patients to manage and cope with their chronic illnesses, and organize communities and advocate policy changes aimed at fostering health improvement. Health professionals also may address environmental concerns, such as safe, accessible water and healthy air. Over the next decade, more behavior change interventions around the world will be directed at changing individual and community behaviors related to basic hygiene and clean water consumption, Briscoe and Abood, 2012, while also trying to reduce non-communicable diseases around the world. The former problems are often a result of poverty and poor living conditions, while the latter stem, in part, from growing influence of the developed world on developing nations. Public health professionals work all over the world and in a variety of settings, including schools, work sites, non-governmental organizations, including voluntary health organizations, medical settings, and communities. And professional fields other than health may also influence health behavior. Since the time of the first edition of this book, there has been increased recognition that what happens in one part of the world affects us all, wherever we may be. Rapid changes in communication technologies have made the world a much smaller place and have accelerated the pace of sharing information and ideas. To the extent that public health is global health and global health is local, we are committed in this volume to explore the use of health behavior theories around the world and to discuss the potential relevance of what is learned in one setting to other areas. While many of our examples are from research conducted in the United States, our perspective is decidedly global. Since the fourth edition of this book was published 7 years ago, the growth of new information and communication technologies has opened up an unprecedented range of strategies for health behavior change programs. Through the internet, mobile devices, and wearables, health behavior change interventions are accessible to people all over the world, regardless of location. The result could be positive changes in health behaviors and health on a scale never before imagined, potentially reaching millions of people rather than hundreds or thousands. There also is increased recognition that the fruits of research take too long to reach people who could benefit from them. Glasgow and Emmons, 2007, Vishwanath, 2006. This has led to an increased emphasis on the dissemination of evidence-based interventions and attention to how interventions are implemented and scaled, and to the growing field of implementation science. Part of the rationale for this book is to speed the dissemination of knowledge about how to use theory, so that theory can inform those who develop and use health behavior interventions around the world. Glands, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 6. Chapter 1, The Scope of Health Behavior. Health experts are challenged to disseminate the best of what is known in new situations. They may also forge and test fundamental theories that drive research and practice in public health, health education, and healthcare. A premise of health behavior, theory, research, and practice is that a dynamic exchange among theory, research, and practice is most likely to produce positive health behaviors. The editors believe, fundamentally, that theory and practice should coexist in a healthy dialectic. They are not dichotomies. The best theory is likely to be grounded in real lessons from practice. Similarly, best practices should be grounded in theory. Canfer and Sheft, 1988, observed that as science and technology advance, The greatest mystery of the universe and the least conquered force of nature remains the human being and his actions and human experiences. The body of research in health behavior has grown rapidly over the past 2.5 decades, and health behavior change is increasingly recognized as critical to meeting public health objectives of the United States and improving the success of public health and medical interventions around the world. While this expanding body of literature improves the science base of health behavior, knowledge management is becoming both a growing challenge and an imperative. The science and art of health behavior and health behavior change are eclectic, are rapidly evolving, and reflect an amalgamation of approaches, methods, and strategies from the social and health sciences. They draw on the theoretical perspectives, research, and practice tools of such diverse disciplines as psychology, sociology, anthropology, communications, economics, and marketing. Health behavior research and practice are also dependent on epidemiology, statistics, and medicine. Big data are now a tool of health behavior and other fields. There is greater emphasis on developing and testing evidence-based interventions than disseminating them widely. Reimer, Glanz, and Rasband, 2001. Evidence-based groups like the Cochrane Collaboration, http://www.cochrane.org, and the CDC's Guide to Community Preventive Services, http://www.thecommunityguide.org, offer regular syntheses of behavioral interventions, some of which include theoretical constructs as variables in analyses of effectiveness. Many kinds of professionals contribute to and conduct health behavior research and intervention programs. Ultimately, their practice is strengthened by the close collaboration among professionals of different disciplines, each concerned with the behavioral and social intervention process, and each contributing a unique perspective. New emphases on interprofessional education may provide the educational foundation to achieve better collaboration across disciplines. While health behavior professionals often have worked this way, there is an increasing emphasis on an interdisciplinary or even a transdisciplinary focus. Turkcan, Kaufman, and Reimer, 2000. Psychology brings to health education a rich legacy of over 100 years of research and practice on individual differences, motivation, learning, persuasion, and attitude and behavior change. Matarazzo, Weiss, Hurd, Miller, and Weiss, 1984, as well as the perspectives of organizational and community psychology. Physicians are important collaborators and are in key roles for effecting change in health behaviors. Roll, Bosch, Holscher, Eccles, and Wenzing, 2007. Likewise, nurses and social workers contribute their particular expertise in working with individual patients and patients' families to facilitate learn-ing, adjustment, and behavior change and to improve quality of life. Other health, education, and human service professionals contribute their special expertise as well, along with those in Glanz, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C01.text V2, June 17, 2015, 10:23 a.m. page 7. Health, Disease, and Health Behavior, The Changing Context 7. The Information Sciences and Related Fields. Increasingly, there are partnerships with genetic counselors, neuroscientists, and other specialists in this rapidly developing field. Health, Disease, and Health Behavior, The Changing Context. The greatest causes of death in the United States and globally are chronic diseases, including heart disease, cancer, lung diseases, and diabetes. Lozano et al., 2012. Behavioral factors, particularly tobacco use, diet and activity patterns, alcohol consumption, sexual behavior, and avoidable injuries, are among the most prominent contributors to mortality. Fisher et al., 2011. Projections of the global burden of disease for the next 2 decades include increases in non-communicable diseases, high rates of tobacco-related deaths, and a dramatic rise in deaths from HIV/AIDS. Abigund, Mathers, Adam, Ortegon, and Strong, 2007, Mathers and Lonker, 2006. Worldwide, the major causes of death by 2030 are expected to be HIV/AIDS, depressive disorders, and heart disease. Mathers and Lonker, 2006. At the same time, in many parts of the world, infectious diseases pose grim threats, especially for the very young, the old, and those with compromised immune systems. Malaria, diarrheal diseases, and other infectious diseases, such as Ebola, SARS, severe acute respiratory syndrome, MERS, Middle East respiratory syndrome, and tuberculosis, in addition to AIDS, are increasing health threats to the poorest people around the world. The PLOS Medicine Editors, 2007. And as with chronic diseases, Their trajectory may be influenced by the application of effective health behavior interventions as well as by social determinants that influence health and illness. Substantial suffering, premature mortality, and medical costs can be avoided by positive changes in behavior at multiple levels. During the past 20 years, there has been a dramatic increase in public, private, and professional interest in preventing disability and death through changes in lifestyle and participation in screening programs. Country and global population health goals are an essential part of the strategy. Example, U.S. Healthy People Goals and WHO Goals. Much of this interest in disease prevention and early detection has been stimulated by the epidemiologic transition from infectious to chronic diseases as leading causes of death, the aging of the global population, rapidly escalating healthcare costs, and data linking individual behaviors to increased risk of morbidity and mortality. The evidence that early detection can save lives from highly prevalent conditions such as breast and colorectal cancer has also been influential. The AIDS epidemic has also contributed. Moreover, around the world, communicable diseases and malnutrition exist alongside increasing problems such as obesity among the middle class. Abigund et al., 2007. Landmark reports in Canada and the United States during the 1970s and 1980s heralded the commitment of governments to health education and promotion. 1986. Lalonde, 1974. U.S. Department of Health, Education, and Welfare, 1979. In the United States, federal initiatives for public health education and monitoring population-wide behavior patterns were spurred by the development of the Health Objectives for the Nation, U.S. Department of Health and Human Services, DHS, 1980, and their successors, Healthy People 2000. National Health Promotion and Disease Prevention Objectives, DHS, 1991, Healthy People Glands, K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 8. 8 Chapter 1, The Scope of Health Behavior. 2010, DHS, 2000, and Healthy People 2020, DHS, 2014b. Similarly, international agencies are drawing attention to the global burden of diseases and health inequalities. World Health Organization, WHO, 2014b. Increased interest in behavioral and social determinants of health behavior change has spawned numerous training programs and public and commercial service programs. Data systems and surveillance initiatives now make it feasible to track trends in risk factors, health behaviors, and healthy environments and policies in the United States and developed countries and, in some cases, to tie these changes to disease incidence and mortality, WHO, 2014a. Indeed, positive change has occurred in several areas. Deaths from coronary heart disease and cancer have declined in the United States, though disparities between racial and economic groups persist. Blood pressure control has improved and mean population blood cholesterol levels have declined. Alcohol-related motor vehicle deaths and overall deaths due to automobile crashes and also deaths from drowning have continued to decrease. Following major litigation against the tobacco industry and a multi-state settlement, there are increased restrictions on tobacco advertising and enforcement of laws against selling tobacco to minors. Glands, Jarrett, Wilson, O'Riordan, and Jacob Areola, 2007. In the United States, fewer adults are using tobacco products. The reduction in adult smoking from 42.4% to 18.1% between 1965 and 2012, Centers for Disease Control and Prevention, 2014, is hailed as one of the top public health achievements of the past century. Rates of HIV/AIDS in the United States have leveled off and transfusion-related HIV infections have decreased markedly. The proportion of women aged 40 and older who have had mammograms within the previous 2 years reached 67.1% in 2010, DHS, 2013. The collective efforts of those in healthcare, health education, and public health have made a difference. While this progress is encouraging, much work remains to be done in the United States and other countries. More adults and children are overweight. Diabetes is increasing to near epidemic proportions. More adolescents are sexually active. 10% of children under 3 years old have not received a basic series of vaccinations for polio, measles, diphtheria, and other diseases. The proportion of adults under 65 years of age with no health insurance coverage has declined recently, but still exceeds 15%. Ethnic minorities and those in poverty still experience a disproportionate burden of preventable disease and disability, and the gap persists between disadvantaged and affluent groups in the use of preventive services. National Commission on Prevention Priorities, 2007. Reducing the global disease burden is critical to the future of the planet. Data from Popkin, 2007, and others show that, like the tobacco epidemic, the obesity epidemic has taken on global proportions. One study of the burden of chronic diseases in 23 low and middle-income countries posits that chronic disease is responsible for 50% of the disease burden in 2005, and estimates an economic loss of almost 84 billion US dollars between 2006 and 2015 if nothing is done to address this burden. Mathers and Lonker, 2006. Changes in healthcare systems are providing new supports and opportunities for health behavior change. Respect for patients' rights and more participatory, patient-centered communications can lead to improved health outcomes. Aurora, 2003, Epstein and Street, 2007. The U.S. Patient Protection and Affordable Care Act included expectations for healthcare systems glands. K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 9. Health Behavior and Health Behavior Change 9. To increase patients' engagement and to measure their success in achieving this outcome. Increasingly, patients are driving their own searches for health information by using the internet. See example Hesse et al., 2005, Reimer et al., 2005. Though disparities remain in information seeking between those of higher and lower socioeconomic status, Ramanathan and Vishwanath, 2006. Clinical prevention and behavioral interventions are often considered cost-effective, but are neither universally available nor equally accessible across racial and socioeconomic groups. Gostin and Powers, 2006, Schroeder, 2007. The rapid emergence of new communication technologies and new models of use for older technologies, such as the telephone, also provide new opportunities and dilemmas. Just a few years ago, new electronic media for interactive health communications consisted mainly of the internet, CD-ROMs, and personal digital assistants. Today, social media, tablets, wireless communications, and personal monitoring devices are widespread. They can serve as sources of individualized health information, reminders, and social support for health behavior change. See Chapter 17. These new technologies also may connect individuals with similar health concerns around the world. Bukachi and Pakenham-Walsh, 2007. This may be especially important for people with rare or stigmatized health conditions. However, the new products of the communication revolution have not reached affluent and disadvantaged populations equally. Vishwanath, 2006. E-health and M-health strategies are becoming important behavior change strategies. Internet and computer-based applications, along with wireless technologies, support many of the strategies based on theories presented in this book. Use of new technologies should be based on theories of health behavior and evaluated. Webb, Joseph, Yardley, and Michie, 2010. In the end, emphasis should be on desired health outcomes. Technology can enable behavior change and measurement of change, but should not be an end in itself. At the same time, new technologies have the potential to cause harm through misleading or deceptive information, promotion of inappropriate self-care, and interference in the patient-provider relationship, although the empirical evidence on harms remains to be documented. Interactive health communications provide new options for behavioral medicine and preventive medicine, and are altering the context of health behavior and health education as they unfold and as their effects are studied. Hesse et al., 2005. Vishwanath, Finnegan, and Golist, Chapter 17 in this book, also have cautioned about the potential for new technologies to exacerbate health disparities. Health behavior and health behavior change. Health behaviors. Positive, informed changes in health behaviors are typically the ultimate aims of health behavior change programs. If behaviors change but health is not subsequently improved, the result is a paradox that must be resolved by examining other issues, such as the link between behavior and health status, or the ways in which behavior and/or health are measured. Informed decision-making is a desirable endpoint for problems involving medical uncertainty. Glands, K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 10. 10 Chapter 1, The Scope of Health Behavior and Studies suggest that shared decision-making may lead to improved patient satisfaction and health outcomes. Reimer, Briss, Zeller, John, and Wolf, 2004. Likewise, environmental or structural interventions to change presumed social environmental determinants of health behaviors are intended to improve health by changing behavior. Smedley and Son, 2000. Story, Hastings, Robinson O'Brien, and Glanz, 2008. Thus, efforts to improve environments, policies, and other outcomes should ultimately be evaluated for their effects on health behaviors and health. If a policy changes but does not lead to measurable changes in behavior, the change may be either too weak, too short-lived, ineffectively implemented, or only a limited determinant of behavior. In its broadest sense, health behavior refers to the actions of individuals, groups, and organizations as well as those actions' determinants, correlates, and consequences, including social change, policy development and implementation, improved coping skills, and enhanced quality of life. Parkerson et al., 1993. This is similar to the working definition of health behavior that Gottman proposed. Although his definition emphasized individuals, it includes not only observable, overt actions, but also the mental events and feeling states that can be reported and measured. Gottman defined health behavior as those personal attributes such as beliefs, expectations, motives, values, perceptions, and other cognitive elements, personality characteristics, including affective and emotional states and traits, and overt behavior patterns, actions, and habits that relate to health maintenance, to health restoration, and to health improvement. Gottman, 1982-1997. Gottman's definition is consistent with and embraces the definitions of specific categories of overt health behavior proposed by Castle and Cobb in their seminal articles, 1966a, 1966b. Castle and Cobb defined three categories of health behavior. Preventive health behavior, any activity undertaken by an individual who believes himself or herself to be healthy for the purpose of preventing or detecting illness in an asymptomatic state. Illness behavior, any activity undertaken by an individual who perceives himself to be ill, to define the state of health, and to discover a suitable remedy. Castle and Cobb, 1966a. Sick role behavior, any activity undertaken by an individual who considers himself to be ill for the purpose of getting well. It includes receiving treatment from medical providers, generally involves a whole range of dependent behaviors, and leads to some degree of exemption from one's usual responsibilities. Castle and Cobb, 1966b. Disciplinary influences on health behavior change over time. Health behavior change has been the focus of multiple fields and professions, including health education, public health, psychology, social work, and various health and medical specialties. Clinical psychologists have traditionally focused on changing individuals, and social work tends to address individuals within their social and family contexts. In the field of health education, the emphasis during the 1970s and 1980s on individuals' behaviors as determinants of health status eclipsed attention to the broader social determinants of health. Advocates of Glanz, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C01.text V2, June 17, 2015, 10:23 a.m. page 11. Settings and audiences for health behavior change 11. System-level changes to improve health called for renewal of a broad vision of health education and promotion, Minkler, 1989, also see Chapter 3. These calls for moving health education towards social action heralded a tighter connection to the broad field of public health. They are consistent with the long-standing concern of public health with the impact of social, economic, and political forces on health. Thus, the idea that focusing on downstream, individual, causes of poor health to the exclusion of the upstream causes risks, missing important opportunities to improve health, McKinley and Marceau, 2000, is not new in public health and health education and promotion, but continues to receive increasing attention. The view of health behavior change strategies as instruments of social change has been renewed and invigorated during the past decade. Policy, advocacy, and organizational change have been adopted as central activities of public health and health education. Most recently, experts have explicitly recommended that interventions on social and behavioral factors related to health should link multiple levels of influence, including the individual, interpersonal, institutional, community, and policy levels. Smedley and Son, 2000. This volume purposefully includes chapters on community and societal influences on health behavior and strategies to affect community and social policy changes in addition to the individual level theories, McLeroy, Bibot, Steckler, and Glanz, 1988, also see Chapter 3. Settings and audiences for health behavior change. During the past century, and more specifically during the past few decades, the scope and methods of health behavior change strategies have broadened and diversified dramatically. This section briefly reviews the range of settings and audiences for health behavior change today. Settings: where are health behavior change strategies provided? 7 major settings are particularly relevant to contemporary health behavior: schools, communities, worksites, healthcare settings, homes, the consumer marketplace, and the communication environment. Schools. Health behavior change programs in schools include classroom teaching, teacher training, and changes in school environments that support healthy behaviors. A. Franks et al., 2007, Lupier et al., 1996. To support long-term health enhancement initiatives, theories of dissemination and implementation can be used to encourage adoption of comprehensive smoking control programs in schools. Diffusion of innovations theory and the theory of reasoned action have been used to analyze factors associated with adoption of AIDS prevention curricula in Dutch schools. Paulison, Koch, Shalma, and Parcel, 1995. Communities. Community-based health promotion draws on social relationships and organizations to reach large populations with media and interpersonal strategies. Models of community engagement glands, K, 2015. Health behavior, theory, research, and practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 12. 12 Chapter 1, The Scope of Health Behavior and Community Mobilization enable program planners both to gain support for and to design suitable health messages and delivery mechanisms. See Chapter 15. Community interventions in churches, clubs, recreation centers, and neighborhoods have been used to encourage healthful nutrition, reduce risk of cardiovascular disease, and use peer influences to promote breast cancer detection among minority women. Worksites. Since its emergence in the mid-1970s, worksite health promotion has grown and has spawned new tools for health behavior change. Because people spend so much time at work, the workplace is a source of both stress and social support. Israel and Sherman, 1990. Effective worksite programs can harness social support as a buffer to stress, with the goal of improving worker health and health practices. Today, many businesses, particularly large corporations, provide health promotion programs for their employees. The U.S. Affordable Care Act provides incentives for employees to alter health behaviors, further advancing worksite health behavior change initiatives. See Chapter 20. Both high-risk and population-wide strategies have been used in worksite health behavior change programs to reduce chronic disease risk factors. Systematic reviews of worksite programs to prevent or reduce obesity have shown success using a variety of strategies. Anderson et al., 2009. Healthcare settings. Health behavior change programs for high-risk individuals, patients, their families, and the surrounding community and in-service training for healthcare providers are all part of healthcare today. The changing nature of health service delivery has stimulated greater emphasis on implementing health behavior change and provider-focused quality improvement strategies in physicians' offices and medical homes, health maintenance organizations, public health clinics, and hospitals. Grohl et al., 2007, Powell et al., 2012. Primary care settings, in particular, provide an opportunity to reach a substantial number of people, Campbell et al., 1994, and to achieve goals of improved population health. The use of community health workers for patients discharged from hospitals is increasingly considered a strategy for reducing readmission rates. Kangovi et al., 2014. Homes. Health behavior change interventions can be delivered to people in their homes, both through traditional public health means, home visits, and through a variety of communication channels and media, such as the internet, telephone calls, and mail. McBride and Reimer, 1999. Strategies, such as mail-tailored messages, Glanz, Schoenfeld, and Stephan, 2010, and motivational interviewing by telephone, Emmons and Rolnit, 2001, make it possible to reach larger groups and high-risk groups in a convenient way that reduces barriers to their receiving motivational messages. In-home coaching that helps people improve their home health environments to support health behavior change has also shown promise. Kegler et al., 2012. Glanz, K., 2015. Health behavior, theory, research, and practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 13. Settings and audiences for health behavior change 13. The consumer marketplace. The advent of home health and self-care products, as well as the use of health appeals to sell consumer goods, has created new opportunities for health education, but also means of misleading consumers about the potential health effects of items they can purchase. Glanz et al., 1995. Social marketing, with its roots in consumer behavior theory, is used increasingly by health educators to enhance the salience of health messages and to improve their persuasive impact. See Chapter 21. Health information policies intended to support informed consumer decision-making, such as policies that encourage adding calorie information to menus, Schwartz, Braxton, and Vieira, 2011, and require graphic warning labels on cigarette packs, Wen, Chalupka, and Fong, 2014, have emerged prominently in the past few years. The communication environment. There have been striking and rapid changes in the availability and use of new information and communication technologies, ICTs, ranging from mass media changes, example, online versions of newspapers and podcasts of radio programs, to personalized, mobile, and interactive media and a host of wireless tools in homes, businesses, and communities. See Chapter 17. These channels can be used in any of the settings described above. Yet they are unique, increasingly prominent and specialized, and provide opportunities for intervention as well as requiring evaluation of their reach and impact on health behaviors. Ahern, Phelan, Liu, and Goldman, 2007. Audiences. Who are the recipients of health behavior change interventions? For health behavior change interventions to be effective, strategies should be designed with an understanding of the recipients, or target audiences, their health, cultural context, and social characteristics, and their beliefs, attitudes, values, skills, and past behaviors. These audiences consist of people who may be reached as individuals, in groups, through organizations, as communities or socio-political entities, or through some combination of these approaches. They may be health professionals, clients, people at risk for disease, or patients. This section discusses four dimensions along which potential audiences can be characterized: socio-demographic characteristics, ethnic or racial background, life cycle stage, and disease or at-risk status. Socio-demographic characteristics and ethnic/racial background. Socioeconomic status has been linked with both health status and health behavior, with less affluent persons consistently experiencing higher morbidity and mortality. Berkman and Kawachi, 2000. Recognition of differences in disease and mortality rates across socioeconomic and ethnic or racial groups has led to increased efforts to reduce or eliminate health disparities. Smedley, Stiff, and Nelson, 2003. World Health Organization, Commission on Social Determinants of Health, 2007. For example, it has long been known that African Americans die at Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C01.text V2, June 17, 2015, 10:23 a.m. page 14. 14 Chapter 1, The Scope of Health Behavior. Earlier ages than whites. Life expectancy for African American males is almost 7 years less than for white males. The difference of 5 years for African American versus white women is smaller, but still alarmingly discrepant. The gaps have grown over the past 3 decades and are even greater for those with lower levels of education and income. P. Franks, Munich, Lubetkin, and Jha, 2006. A variety of socio-demographic characteristics, such as gender, age, race, marital status, place of residence, and employment, characterize audiences for changes in health behaviors. The United States has experienced a rapid influx of new immigrant populations, especially from Africa and Europe, and the proportion of non-white minority residents continues to climb. These factors, while generally not modifiable within the bounds of health education programs, are important to understand in order to guide the targeting of strategies and educational materials, and to identify channels and media through which to reach consumers. Health behavior interventions should be appropriate to the educational and reading levels of particular target audiences and be compatible with their ethnic and cultural backgrounds. Resnico, Braithwaite, Diorio, and Glanz, 2002, and their access to and facility with technology. Life cycle stage. Health education is provided for people at every stage of the life cycle, from childbirth education whose beneficiaries are not yet born to self-care education and rehabilitation for the very old. Developmental perspectives help to guide the choice of intervention and research methods. Children may have misperceptions about health and illness, such as thinking that illnesses are a punishment for bad behavior. Armsden and Lewis, 1993. Knowledge of children's cognitive development helps provide a framework for understanding these beliefs and ways to respond to them. Adolescents may feel invulnerable to accidents and chronic diseases. The health belief model, see Chapter 5, is a useful framework for understanding the factors that may predispose youth to engage in unsafe sexual practices. Healthy People 2020 goals stress reaching people in every stage of life, with a special focus on vulnerabilities that may affect people at various life cycle stages, DHS 2014b. Disease and at-risk status. People who are diagnosed with life-threatening diseases often experience not only symptoms, but also the distress associated with their prognosis and having to make decisions about medical care, see Chapter 12. Illness may compromise their ability to attend to new information or develop new skills at critical points. Because of this, timing, channels, and audiences for patient education should be carefully considered. Successful patient education depends on a sound understanding of the patient's view of the world, Glanz and Oldenburg, 2001. For individuals at high risk due to family history or identified risk factors, health behavior change interventions may have heightened salience when linked to strategies for reducing individual risk, Weinstein, Sandman, and Blaylock, 2008. Even so, strategies used to enable initial changes in behavior, such as quitting smoking, may be insufficient to maintain behavior change over the long term, even in these people. Models and Theories of Health Behavior can suggest strategies to Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, B01.text V2, June 17, 2015, 10:23 a.m. page 15. Progress in Health Behavior Research and Practice 15. Prevent relapse and enhance maintenance of recommended practices for high-risk individuals, Glanz and Oldenburg, 2001. Progress in Health Behavior Research and Practice. Over the past 3 decades, many studies, large and small, have been conducted to identify and test the most effective methods to achieve health behavior change. Example, Carlton, Lassiter, Essoff, Feldman, and McKinley, 1995, Farquhar et al., 1990, Glasgow, Terborg, Hollis, Severson, and Bowles, 1995, Lukier et al., 1994, Sorensen et al., 1996, Winkleby, 1994. More precise quantification of personal health behaviors and improved health outcomes have grown from partnerships among behavioral scientists, biomedical experts, and people from other fields, including education and the information sciences. Although many large studies were disappointing in the lack of significant results or smaller results than expected, several behavior change campaigns produced behavior changes conducive to health, Hornet, 2002. These experiences suggest that health education interventions must be carefully planned, developed from strong formative research, and theory-based. Randolph and Vishwanath, 2004, also see Chapter 19. While randomized controlled trials provide the most rigorous test of health behavior interventions, the past 2 decades have been marked by an increase in carefully designed evaluation research in health education, which combines quantitative and qualitative methods. Evaluations of community-based AIDS pre-Vention projects, Jans et al., 1996, and coalitions for prevention of alcohol, tobacco, and other drug abuse, Butterfoss, Goodman, and Wandersman, 1996, exemplify applications of community research methodologies that offer in-depth process information across multiple programs in diverse settings. Similarly, new statistical methods and adaptive trials may ultimately permit faster answers and the capacity to answer more questions through more efficient trial design. Overall, there has been a growing recognition of the importance of building an evidence base in the domain of health-related behavior change interventions, Reimer, Glanz, and Rasband. 2001. Today, systematic reviews and meta-analyses of health behavior change studies are both common and expected to guide future work. It has been nearly 20 years since the uptick in quantitative synthesis began to grow. A review of health education research between 1994 and 2003 found a significant increase in use of quantitative statistics, while also finding that the most common types of articles were those that addressed cross-sectional studies and review articles, Merrill, Lindsay, Shields, and Stoddard, 2007. That review was limited to 3 health education journals. Other reviews of research design and statistics also found a preponderance of correlational and descriptive studies, Noren Zimmerman, 2005, Painter, Borba, Hines, Mays, and Glanz, 2008, Weinstein, 2007. As the research literature grows, it is critical that the evidence base and the methods behind the evidence are accessible to both researchers and practitioners around the world. Von Elm et al., 2007. Evidence reviews are defined as those using formalized methods to collect, prioritize, and weigh the findings of intervention. Research. Important progress has been made over the past 10 to 15 years in improving the process of and guidance for conducting systematic reviews and meta-analyses. Hoffman et al., 2014, Maher, Liberati, Tetzlaff, Altman, and the Prisma Group, 2009. The U.S. Task Force on Glands, K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C01.text V2, June 17, 2015, 10:23 a.m. page 16. 16 Chapter 1, The Scope of Health Behavior. Community preventive services is defining, categorizing, summarizing, and rating the quality of evidence on the effectiveness of population-based interventions for disease prevention and control, providing recommendations on these interventions and methods for their delivery based on the evidence, and identifying and summarizing research gaps. Briss et al., 2000, DHHS, 2014a. Parallel efforts are underway in other countries as well, such as the work in England being conducted by the National Institute for Health and Clinical Excellence, NICE, 2014. Observations by McGuinness, 1994, are still relevant today. The challenge of understanding and improving health behavior is one of the most complex tasks yet confronted by science. To competently address that challenge, the research community must simply do more and do it better in certain key areas of behavioral research. A coordinated and focused effort is essential to resolve many of the most vexing health issues facing our society. Smedley and Syme. 2000, integration of the best available knowledge from theory, research, and behavior change practice can advance that agenda in the years ahead. Health Behavior Foundations for Theory, Research, and Practice. This chapter has discussed the dynamic nature of health behavior today in the context of changing patterns of disease and trends in social interaction and communication, healthcare, health education, and disease prevention in the United States and globally. It has provided definitions of health behavior and describes the broad and diverse parameters of this maturing field. Although thousands more studies of health behavior change have been conducted and reported since the last edition of this book, their variable and sometimes disappointing results raise new questions and pose methodological, theoretical, and substantive challenges. The importance of theory, research, and practice and the interrelationships among them are set against the backdrop of the urgent, growing, and complex imperative to improve the health of populations around the world and to do so in a context that recognizes that health services are only some of the forces that influence health status. Today's students, researchers, and practitioners can make a difference in the burden of illness and in the potential to develop effective, scalable interventions to improve health. References: Abigund, D. O., Mathers, C. D. Adam, T. Ortegone, M. and Strong, K. 2007. The Burden and Costs of Chronic Diseases in Low-Income and Middle-Income Countries. Fitting Theory to Research and Practice. Building Bridges and Forging Links. Effective health behavior change depends on marshaling the most appropriate Chapter 2. Theory, Research, and Practice. In Health Behavior. The editors. Theory, Research, and Practice, Interrelationships. Aristotle distinguished between theoria and praxis. Theoria signifies those sciences and activities concerned with knowing for its own sake, whereas praxis corresponds to action or doing. This contrast between theory and practice, Bernstein, 1971, permeates Western philosophical and scientific thought from Aristotle to Marx and on to Dewey and other contemporary 20th century philosophers. Theory and practice have long been regarded as opposites with irreconcilable differences. Within academic departments, there is often a hierarchical split between those who conduct theoretical work and those who pursue practice. Dewey attempted to resolve the dichotomy by focusing on similarities and continuities between theoretical and practical judgments and inquiries. He described experimental knowing as essentially an art that involves a conscious, directed manipulation of objects and situations. The craftsman perfects his art, not by comparing his prod up to some ideal model, but by the cumulative results of experience which benefits from tried and tested procedures, but always involves risk and novelty. Bernstein, 1971. Dewey thus described empirical investigation, that is, research, as the ground between theory and practice and the testing of theory in action. Although the perception of theory and practice as a dichotomy has a long tradition in intellectual thought, Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 24. 24 Chapter 2, Theory, Research, and Practice in Health Behavior. We follow in Dewey's tradition and focus on the similarities and continuities rather than on the differences. Theory, research, and practice are a continuum along which the skilled professional should move with ease. Not only are they related, but they are each essential to understanding health behavior and health behavior change. There is a tension between theory and practice that one must navigate continually, but they are not in opposition. Theory and practice enrich one another by their dynamic interaction. The best theory is informed by practice. The best practice should be grounded in theory. There is too little of both in health behavior. And as Green, 2006, has written compellingly, there is also a need for more practice-based evidence. Researchers and practitioners may differ in their priorities, but the relationship between research and its application can and should move in both directions. There is a critical need for more reflective practitioners, professionals who can ensure that theories and practice build on each other. Sean, 1983. Among the most important challenges facing us is to understand health behavior and to transform knowledge about behavior into effective strategies for health enhancement. Research in health behavior ultimately will be judged by its contributions to improving the health of populations. Although basic behavioral research is important in developing theories, we must ultimately test our theories iteratively in real-world contexts. Green, 2006. When we do so, theory, research, and practice begin to converge. The authors of this book examine theories in light of their applicability. By including an explanation of theories and their application in each chapter, we aim to break down the dichotomy between theory and practice. Relationships among theory, research, and practice are not simple or linear. The larger picture of health improvement and disease reduction is better described as a cycle of interacting types of endeavors, including fundamental research, research into determinants as well as development of methodologies, intervention research, research aimed toward change, surveillance research, research that tracks population-wide trends, including maintenance of change, and application and program delivery. Hyatt and Reimer, 1999. At the heart of this cycle is knowledge synthesis. Regularly updated critical appraisals of the available literature are central to identifying interventions that should be disseminated in order to reduce the burden of disease. Reimer, Glanz, and Rasband, 2001. There is increasing recognition that, as Green has stated, if we want more evidence-based practice, we need more practice-based evidence. Green and Glasgow, 2006. This fifth edition of Health Behavior, Theory, Research, and Practice aims to help healthcare providers, public health professionals, behavior change experts, and educators, whatever their backgrounds or disciplines, to understand some of the most important theoretical underpinnings of health behavior and to use theory to inform research and practice. The authors of this volume believe that there is nothing so useful as a good theory. Lewin, 1935. Each chapter demonstrates the practical value of theory. Each summarizes what was learned through conceptually sound research and practice. and each draws the linkages between theory, research, and practice. Professionals charged with responsibility for improving health behavior are, by and large, interventionists. They are action-oriented. They use their knowledge to design and implement programs to improve health. This is true whether they are working to encourage glands, K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C02.text V2, June 17, 2015, 11:10 a.m. page 25. Theory, Research, and Practice, Interrelationships 25. Health-enhancing changes in individual or community behavior or conditions. It is equally true of most health behavior research. Often, in the process of attempting to change behavior, environments, or policies, researchers must do precisely what practitioners do, develop and deliver interventions. At some level, both practitioners and researchers are accountable for results, whether these are measured in terms of participants' satisfaction with programs or changes in awareness, knowledge, attitudes, beliefs, or health behaviors, improved decision-making, institutional norms, community integration, or more distal results, including morbid ITY, mortality, and quality of life. They may assess these results anecdotally, complete in-depth qualitative assessments, or conduct rigorous empirical evaluations. The design of interventions that yield desirable changes can be improved when it is done with an understanding of theories of behavior change and an ability to use them skillfully in Research and Practice, Grohl, Bosch, Hulscher, Eccles, and Wenzing, 2007. Most public health educators and managers, and behavior change clinicians, work in situations in which resources are limited. This makes it essential that they reach evidence-informed judgments about the choice of interventions, both in the interest of efficiency and to improve the odds of success. There may be no second chance to reach a critical target audience. A synthesis of theory, research, and practice will advance what is known about health behavior. A health behavior change agent without a theory is like a mechanic or a technician, whereas the professional who understands theory and research comprehends the why and can design and craft well-tailored interventions. In health behavior, the circumstances include the nature of the target audience and the setting, resources, goals, and constraints. Bartholomew, Parcel, Koch, and Gottlieb, 2006. There are a number of good planning models available to help professionals and communities decide which problems and variables to focus on and also help them understand key elements of the background situation. See Chapter 19 for examples. An understanding of theory may guide users to measure more carefully and astutely in order to assess the impact of interventions. Glasgow and Linan, 2008, Grohl et al., 2007. Learning from successive interventions and from published evidence strengthens the knowledge base of individual health professionals. Over time, such cumulative learning also contributes to the knowledge base of all. The health professional in a health maintenance organization who understands how to use the trans-theoretical model or social cognitive theory, SCT, may be able to design better interventions to help patients lose weight or stop smoking. The community health educator who understands principles of social marketing and media communication can make better use of the mass media than one who does not. The nurse who recognizes that observational learning is important to how people learn, as postulated in SCT, may do a better job of teaching diabetics how to administer their injections. A working knowledge of community organization can help the educator identify and mobilize key individuals and groups to develop or maintain a health promotion program. The physician who understands interpersonal influence can communicate more effectively with patients. The health psychologist who understands the trans-theoretical model of change will know how to design better smoking cessation and exercise interventions and how to tailor them to the needs of his or her patients. Glands, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glands, C02.text V2, June 17, 2015, 11:10 a.m. page 26. 26 Chapter 2, Theory, Research, and Practice in Health Behavior. What is theory? A theory is a set of interrelated concepts, definitions, and propositions that present a systematic view of events or situations by specifying relations among variables in order to explain and predict events or situations. The notion of generality, or broad application, is important, as is testability, Van Rijn and Heaney, 1992. Theories are by their nature abstract. That is, they do not have a specified content or topic area. Like an empty coffee cup, they have a shape and boundaries, but nothing concrete inside. They only come alive in public health and health behavior when they are filled with practical topics, goals, and problems. A formal theory, more an ideal than a reality, is a completely closed deductive system of propositions that identifies the interrelationships among the concepts and is a systematic view of the phenomena. Laylock, 1969, Curlinger, 1986. In reality, there is no such system in the social sciences or health promotion and education. It can only be approximated. Laylock, 1969. Theory has been defined in a variety of ways, each consistent with Curlinger's definition. Table 2.1 summarizes several definitions of theory. These definitions, put forth in the 1970s and 1980s, have stood the test of time. They have been articulated in more recent works without substantive changes. Isaac and Michael, 1995, Sussman, 2001. Theories are useful during the various stages of planning, implementing, and evaluating interventions. Program planners can use theories to shape the pursuit of answers to why, what, and how. That is, theories can be used to guide the search for why people are not following public health and medical advice or not caring for themselves in healthy ways. They can help pinpoint what one needs to know before developing and organizing an intervention program. They can provide insight into how to shape program strategies to reach people and organizations and make an impact on them. They can also help to identify what should be monitored, measured, and/or compared in a program evaluation. Glanz, Lewis, and Reimer, 1996. Glanz, Reimer, and Lewis, 2002, Glasgow and Linan, 2008. Thus, theories and models explain behaviors and suggest ways to achieve behavior change. Explanatory theories, often called a theory of the problem, help to describe and identify why. Table 2.1 Definitions of theory. Definition source a set of interrelated constructs, concepts, definitions, and propositions that presents a systematic view of phenomena by specifying relations among variables, with the purpose of explaining and predicting phenomena. Curlinger, 1986, page 9. A systematic explanation for the observed facts and laws that relate to a particular aspect of life. Babby, 1989, page 46. Knowledge writ large in the form of generalized abstractions applicable to a wide range of experiences. McGuire, 1983, page 2. A set of relatively abstract and general statements which collectively purport to explain some aspect of the empirical world. Chaffetz, 1978, page 2. An abstract, symbolic representation of what is conceived to be reality, a set of abstract statements designed to fit some portion of the real world. Zimbardo, Ebbesen, and Maslach, 1977, page 53. Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches. Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 27. What is theory? 27. A problem exists. These theories also predict behaviors under defined conditions. They guide the search for modifiable factors like knowledge, attitudes, self-efficacy, social support, lack of resources, and so on. Change theories, or theories of action, guide the development of interventions. They also form the basis for evaluation, pushing the evaluator to make explicit her or his assumptions about how a program should work. Implementation theories are change theories that link theory specifically to a given problem, audience, and context. Institute of Medicine, 2002, also see Chapter 16. These two types of theories often have different foci, but are complementary. Even though various theoretical models of health behavior may reflect the same general ideas, each theory employs a unique vocabulary to articulate the specific factors considered important. The why tells us about the processes through which changes occur in particular. Target variables. Theories vary in the extent to which they have been conceptually developed and empirically tested. Bandura, 1986, stressed that theories are interpreted in different ways depending on the stage of development of the field of study. In some younger fields, theories specify the determinants governing the phenomena of interest. The term theory is used in the latter sense in health behavior, theory, research, and practice, because this field is still relatively young. As we discuss later in this chapter, many new theories and models have been and continue to be proposed in health behavior. Michie, West, Campbell, Brown, and Gainforth, 2014. The proliferation of theories in health behavior poses a challenge. When do we accept a theory as truly advancing our understanding of a phenomenon? Lakatos and Musgrave, 1970, though referring to theories in physics, offer some rules of thumb. A new theory can be considered acceptable if it explains everything that the prior theories explain, provides explanations for phenomena that could not be explained by prior theories, and identifies conditions under which the theory could be falsified. Another expectation of an established theory is that there should be a body of research testing it and supporting it by multiple scientists beyond the original developers. Concepts, constructs, and variables. Concepts are the major components of a theory. They are its building blocks or primary elements. Concepts can vary in the extent to which they have meaning, or can be understood outside the context of a specific theory. When concepts are developed or adopted for use in a particular theory, they are called constructs. Perlinger, 1986. The term subjective normative belief is an example of a construct within Agin and Fishbein's 1980 theory of reasoned action. See Chapter 6. This specific construct has a precise definition in the context of that theory. Another example of a construct is perceived susceptibility in the health belief model. See Chapter 5. Variables are the empirical counterparts, or operational forms, of constructs. They specify how a construct is to be measured in a specific situation. Variables should be matched to constructs when identifying what should be assessed in the evaluation of a theory. Driven Program. Glanz, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 3:21. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 28. 28 Chapter 2, Theory, Research, and Practice in Health Behavior. Principles. Theories go beyond principles. Principles are general guidelines for action. They are broad and nonspecific and may actually distort realities or results based on research. Principles may be based on precedent or history or on research. At their best, principles are based on accumulated research. In this best form, principles are the basis for hypotheses, leading ideas in the words of Dewey, and serve as our most informed hunches about how or what we should do to obtain a desired outcome in a target population. Principles should not be so broad that they invite multiple interpretations and are therefore unreliable. Nor should they be ambiguous so that they can be all things to all people. Models. Health behavior and the guiding concepts for influencing it are far too complex to be explained by a single, unified theory. Models draw on a number of theories to help understand a specific problem in a particular setting or context. They are often informed by more than one theory, as well as by empirical findings. Urban Dennett, 1991. Several models that support program planning processes are widely used in health promotion and education. Green and Kreuter's Proceed model, 2005. Also see Chapter 19, and Social Marketing, see Chapter 19, and Ecological Models, McLeroy, Bebeau, Steckler, and Glanz, 1988. Also see Chapter 3. Paradigms for Theory and Research in Health Behavior. A paradigm is a basic schema that organizes our broadly based view of something. Babby, 1989. Paradigms are widely recognized scientific achievements that, for a time, provide model problem-solving approaches to a community of practitioners and scientists. They include theory, application, and instrumentation and constitute models that represent coherent traditions of scientific research. Kuhn, 1962. Paradigms gain status because they are more successful than their competitors at solving pressing problems. Kuhn, 1962. But they can also impede scientific progress by protecting inconsistent findings until a crisis point is reached. These crisis points lead to scientific revolutions. Paradigms create boundaries within which the search for answers occurs. They do not answer particular questions, but they do direct the search for answers. Babby, 1989. Paradigms circumscribe or delimit what is important to examine in a given field of inquiry. The collective judgments of scientists define the dominant paradigm that constitutes the body of science. Wilson, 1952. In the science of health behavior, and in this text, the dominant paradigm that supports the largest body of theory and research is logical positivism, or logical empiricism. This basic view, developed in the Vienna Circle from 1924 to 1936, has two central features. 1. An emphasis on the use of induction, or sensory experience, feelings, and personal judgments as the source of knowledge, and 2. The view that deduction is the standard for verification or confirmation of theory, so that theory must be tested through empirical methods and systematic Glanz, K. 2015. Health behavior, theory, research, and practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 3:21. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glans, C02.text V2, June 17, 2015, 11:10 a.m. page 29. Paradigms for Theory and Research in Health Behavior, 29. Observation of Phenomena, Runes, 1984. Logical empiricism reconciles the deductive and inductive extremes. It prescribes that the researcher begin with a hypothesis deduced from a theory and then test it, subjecting it to the jeopardy of disconfirmation through empirical testing, McGuire, 1983. An alternative worldview that is also important in health behavior relies more heavily on induction and is often identified as a predominantly constructivist paradigm. This perspective argues that the organization and explanation of events should be revealed through a process of discovery rather than organized into prescribed conceptual categories before a study begins. In this paradigm, data collection methods such as standardized questionnaires and predetermined response categories have a limited place. Ethnography, phenomenology, and grounded theory are examples of approaches using a constructivist paradigm, Kendler, 2005. Strauss, 1987. It has become increasingly common in the health behavior field for work to originate in a constructivist paradigm and shift toward a focus on answering specific research questions using methodologies from the logical positivist paradigm. The use of mixed methods that include both qualitative and quantitative measures has gained traction in health behavior, psychological research, and other social sciences, Cacioppo, Semin, and Bernson, 2004, Creswell, 2013. However, without quantitative data, a theory is unlikely to be accepted. Lewin's meta-theory stipulates the rules to be followed for building good theory. The rules are consistent with logical positivism, but focus on his view that the function of social psychology is to further understanding of the interrelationships between the individual and the social environment. Gold, 1992. This meta-theory is an orientation, or approach, distinct from Lewin's specific field theory, Gold, 1992, and it has been influential in health behavior theory. Since the earliest attempts to use social science to solve public health problems, Rosenstock, 1990, key rules of Lewin's meta-theory include analysis that starts with the situation as a whole, contemporaneity, a dynamic approach, a constructive method, a mathematical representation of constructs and variables, and a psychological approach that explains both inner experiences and overt actions from the actor's perspective. Lewin, 1951. The last of these rules implies a single level of analysis requiring closed theory and poses a serious limitation to solving the problems of contemporary health behavior. It raises the issue, one that those concerned with health behavior often grapple with, that we must often trade off theoretical elegance in favor of relevance. Gold, 1992. Ultimately, those who study and practice in fields that involve health behavior are generally concerned with approaches to solving social problems, and in many cases, solving some of the most significant threats and problems facing the world today. In other words, they are grappling with fundamental challenges of behavior change in the health domain. Considerable scholarly and practitioner effort has been devoted to developing techniques that change behavior. Although these efforts grew out of a desire to produce a better world, techniques that push people to change were experienced by many as manipulative, reducing freedom of choice, and sustaining a balance of power in favor of the change agent. Kipnis, 1994. A paradigm shift occurred, and many techniques for promoting individual behavior change, example, social support, empowerment, and personal growth, shifted focus to become based on reducing obstacles to change and promoting informed decision-making, rather than on pushing people to change. Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 3:21. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches glans, C02.text V2, June 17, 2015, 11:10 a.m. page 30. 30 Chapter 2, Theory, Research, and Practice in Health Behavior. New paradigms for understanding, studying, and applying knowledge about human behavior continue to arise and may be influential in the future of applied social sciences in health behavior and education. The Institute of Medicine's Committee on Capitalizing on Social Science and Behavioral Research to Improve the Public's Health recommended strongly that interventions on social and behavioral factors should link multiple levels of influence rather than focusing on a single or limited number of health determinants. Smedley and Son, 2000, page 7. Today, this recommendation is echoed as health educators and social scientists struggle with some of the most challenging health behavior issues, such as tobacco control and obesity prevention, at a time when ecological models are beginning to be more clearly articulated and studied. See Chapter 3. Trends in use of health behavior theories and models. Theories that gain recognition in a discipline shape the field, help to define the scope of practice, and influence the training and socialization of its professionals. Today, no single theory or conceptual framework dominates research or practice for understanding and changing health behavior. Instead, one can choose from a multitude of theories. Previous reviews of the most often used theories. For the first 4 editions of this book, we reviewed a sample of publications to identify the most often used theories. In a review of 116 theory-based articles published between 1986 and 1988 in 2 major health education journals, conducted during planning for the first edition of this book, we found 51 distinct theoretical formulations. At that time, the 3 most frequently mentioned theories were social learning theory, the theory of reasoned action, and the health belief model, Glanz, Lewis, and Reimer, 1990. To plan for the second edition of this book, we reviewed 526 articles from 24 journals in health education, medicine, and behavioral sciences, published from mid-1992 to mid-1994. 66 theories and models were identified, and 21 of these were mentioned 8 times or more. 2/3 of the total instances of theory used in the 497 articles involving one or more of the 21 most common theories/models were accounted for by the first 8, the health belief model, social cognitive theory, self-efficacy, Bandura. 1997, the theory of reasoned action/theory of planned behavior, community organization, the trans-theoretical model/stages of change, social marketing, and social support/social networks, Glanz et al., 1996. In our review of all issues of 12 journals in health education, health behavior, and preventive medicine published in 1999 and 2000, conducted for the 3rd edition of this book, Glanz et al., 2002, 10 theories or models clearly emerged as the most often used. The first 2, and by far the most dominant, were social cognitive theory and the trans-theoretical model/stages of change. The remainder of the top 10 theories and models were the health belief model, social support and social networks, patient-provider communication, the theory of reasoned action and theory of planned behavior, stress and coping, community organization, ecological models/social ecology, and diffusion of innovations. Glanz, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 31. Trends in use of health behavior theories and models 31. In a review of theory use in published research between 2000 and 2005, we found that the most often used theories were the trans-theoretical model, social cognitive theory, and the health belief model, Painter, Borba, Hines, Mays, and Glanz, 2008. Overall, the same theories found to be dominant in 1999 and 2000 were still dominant. Like previous reviews, this review revealed that dozens of theories and models were used, though only a few of them were used in multiple publications and by several authors. Some were minor variations of another theory. Several key constructs cut across the most often cited models for understanding behavior and behavior change, the importance of the individual's view of the world, multiple levels of influence, behavior change as a process, motivation versus intention, intention versus action, and changing behavior versus maintaining behavior change, Glanz and Oldenburg, 2001. Updated review of the most often used theories. There has been a continuing proliferation of theories and models up to the present. Rather than conducting a new literature review for the 5th edition of this book, we looked to published reviews. We identified several reviews that examined the use of theory for behavior change in specific behavioral categories, such as dietary change, cancer screening, and reducing sexual risk, Albada, Ozzums, Fencing, and Van Domen, 2009, Ammerman, Lindquist, Lohr, and Hersey, 2002, Gardner, Wardle, Poston, and Croker, 2011, Glanz and Bishop, 2010, Legler et al., 2002, Knorr, Bennett, and Harris, 2007, Knorr, Black, and Pierce, 2009, Prestwich et al., 2013, Taylor, Connor, and Lawton, 2011, Webb, Joseph, Yardley, and Michie, 2010. A recently published compendium of behavior change theories, using clearly defined inclusion criteria, provides summaries of 83 theories and models, Michie et al., 2014. As these reviews assessed primarily individual outcomes of behavior change interventions, we also examined reviews of strategies. For implementation and dissemination in health and mental health services, Powell et al., 2012, Tabak, Kung, Chambers, and Brownson, 2012, and a review of social ecological contextual levels of health promotion interventions across a 20-year period, Golden and Earp, 2012. These reviews point to several key conclusions about the use of theories and models for health behavior change research. The first is the inescapable observation that there are many available theories and models. For example, the acknowledged selective review of 83 theories in Michie and others' book, 2014, the 68 distinct strategies identified by Powell and others, 2012, and the 61 models included in Tabak and others' dissemination and implementation research review, 2012. These theories and models are not mutually exclusive. As Tabak and colleagues have stated, there is substantial overlap between models, as the included constructs are often similar, 2012. Review authors have used different coding schemes to classify the theories in their reviews. A novel approach taken by Michie and others, 2014, to examine the interconnectedness of the 83 theories summarized in their book was to use network analysis methods to examine contributions, links, and patterns among the theories they describe. Our synthesis of the various reviews, and the Michie et al. Network analysis, 2014, leads to the conclusion that, indeed, only a small number of theories and models have been widely used and or have informed numerous other theories. In fact, those theories are the same ones Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 32. 32 Chapter 2, Theory, Research, and Practice in Health Behavior. Identified in the last 3 editions of this book, the Health Belief Model, Social Cognitive Theory, and Social Learning Theory, its predecessor, Theory of Planned Behavior, and Theory of Reasoned Action, its predecessor, Social Support, Diffusion of Innovations, and the Social Ecological Model. A third issue in examining the use of theories and models for health behavior change is the level at which they seek to understand and or influence behavior and its determinants. See Chapter 3. Golden and Earp reviewed 157 intervention articles published in the journal Health Education and Behavior, and its predecessor through 1997, Health Education Quarterly, between 1989 and 2008. They coded intervention levels of focus according to the social ecological model and found that, across all settings, theories, topics, and time periods, the intervention strategies and targets for change were most likely to be at the individual and interpersonal levels, and were less often at the institutional, community, and policy levels. Golden and Earp, 2012. In contrast, Tabak and colleagues, 2012, found that most of the models for dissemination and implementation research that they identified were distributed across all levels of the social ecological model. The focus and scope of the 2 reviews was very different, with Golden and Earp looking at a single journal over time, and the Tabak review examining inherently multi-level issues, dissemination and implementation, across a wide range of sources. Viewing these contrasting findings through the interdisciplinary lens of health behavior research and practice, an important conclusion is that broader exposure across topics and published sources appears to be associated with greater application across multiple levels of study and intervention. How are theories being used in health behavior research and practice? Along with the published observations about which theories are being used, concerns have been raised about how theories are used, or not used, in research and practice. A common refrain is that researchers may not understand how to measure and analyze constructs of health behavior theories, Marsh, Johnson, and Carey, 2001, Rajewski, Brawley, Macaulay, and Rapp, 2000, or that they may pick and choose variables from different theories in a way that makes it difficult to ascertain the role of theory in intervention development and evaluation, Michie et al., 2014. Considerable conceptual confusion among both researchers and practitioners about interrelationships among related theories and variables has also been observed, Rosenstock, Strecker, and Becker, 1988, Weinstein, 1993. Others have cautioned about the limitations of theory testing because of over-reliance on correlational designs, Weinstein, 2007, and the paucity of studies that empirically compare more than one theory, Noor and Zimmerman, 2005. Weinstein and Rothman, 2005. The difficulty of reliably translating theory into interventions to improve clinical effectiveness has led to calls for more pragmatic trials and increasing attention to the generalizability and translation of interventions into real-world clinical practice, Rothwell, 2005, and community settings, Rohrbach, Reina, Sussman, and Valente, 2006. These are reasonable questions that should encourage us all to question how we use theory, how we test theory, how we turn theories into interventions, and what conclusions we draw from research. Glanz, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 33. Selection of theories for this book 33. Building on our distinctions among the type and degree of theory use, Glanz, 2002, page 546, our review of theory used from 2000 to 2005 classified articles that employed health behavior theory along a continuum consisting of these 4 categories. 1. Informed by theory, a theoretical framework was identified, but no or limited application of the theory was used in specific study components and measures. 2. Applied theory, a theoretical framework was specified and several of the constructs were applied in components of the study. 3. Tested theory, a theoretical framework was specified and more than half the theoretical constructs were measured and explicitly tested, or 2 or more theories were compared to one another in a study. Or 4. Building/creating theory, new or revised/expanded theory was developed using constructs specified, measured, and analyzed in a study. Of all the theories used in a sample of articles, N equals 69 articles using 139 theories, 69.1% used theory to inform a study, 17.9% of theories were applied, 3.6% were tested, and 9.4% involved building/creating theory, Painter et al., 2008. These findings lead us to reaffirm calls by Noren Zimmerman, 2005, and Weinstein and Rothman, 2005, for thorough application and testing of health behavior theories to advance science and move the field forward. Similar observations have been made by Michie and others, 2014, as well. Selection of theories for this book. Our selection of theories and models for inclusion in the 5th edition of Health Behavior, Theory, Research, and Practice was based on the published information summarized above, including an updated synthesis of reviews of theory use in the health behavior literature. Each of the most often cited theories and models is the focus of a chapter in this volume. They have been selected to provide readers with a range of theories representing different units of intervention, exampled individuals, groups, and communities. They were also chosen because they represent, as in the case of social cognitive theory, the trans-theoretical model, and the health belief model, dominant theories of health behavior and health behavior change. Others, like social marketing, intervention mapping, and the proceed/proceed model, and community organization, were chosen for their practical value in applying theoretical formulations in a way that has demonstrated usefulness to professionals concerned with health behavior change. Our selection of theories also reflects some difficult editorial decisions. 3 criteria helped us to define our selection. First, we determined that, to be included, a theory must meet basic standards of adequacy for research and practice, thus having the potential for effective use by health education practitioners. Second, there must be evidence that the theory is being used in current health behavior research. That is why, example, we include the health belief model rather than Lewin's field theory. The third criterion is that there must be at least promising, if not substantial, empirical evidence supporting the theory's validity in predicting or changing health behaviors. This does not preclude the possibility of mixed findings and critiques of the evidence, which we believe are important to bring to light. In the later sections of the book, a purpose, theme, or focus rather than a theory is the identifying title for a chapter, as in the case of Chapter 13, on interpersonal glands, K. 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 34. 34 Chapter 2, Theory, Research, and Practice in Health Behavior. Communication, which describes theories of interpersonal communication and social influence and illustrates their utility for health behavior. Chapter 15 on community engagement and community organization is named for this approach to intervention strategies rather than for the convergent theoretical bases that form the foundation for community organization work. Chapters in Part 5 present the intervention mapping and the proceed-proceed model for program planning, social marketing, and behavioral economics, each of which draws on multiple theories to understand health behavior and assist in development of effective intervention programs and strategies. We recognize the lack of consensus regarding the definition and classification of theories. We have taken a liberal, ecumenical stance toward theory. We concede that the lowest common denominator of the theoretical models herein might be that they are all conceptual, or theoretical frameworks, models, or broadly conceived perspectives used to organize ideas. Nevertheless, we have not abandoned the term theory, because it accurately describes the spirit of this book and describes the goal to be attained for developing frameworks and tools for refining health education research and practice. Fitting theory to research and practice, building bridges and forging links. Effective health behavior change depends on marshaling the most appropriate theory and practice strategies for a given situation. Different theories are best suited to different units of practice, such as individuals, groups, and organizations. For example, when one is attempting to overcome women's personal barriers to obtaining mammograms, the health belief model may be useful. The trans-theoretical model may be especially useful in developing smoking cessation interventions. When trying to change physicians' mammography practices by instituting reminder systems, dissemination and implementation science approaches are more suitable. At the same time, physicians might use the trans-theoretical model to inform their discussions with individual patients about getting a first mammogram or annual screening. The choice of a suitable theory or theories should begin with identifying the problem, goal, and units of practice. Sussman and Sussman, 2001, Van Ryn and Heaney, 1992, not with selecting a theoretical framework, because it is intriguing, familiar, or in vogue. As Green and Kreuter, 2005, have argued, one should start with a logic model of the problem and work backward to identify potential solutions. The adequacy of a theory is most often assessed in terms of three criteria. 1, its logic, or internal consistency, in not yielding mutually contradictory derivations. 2, the extent to which it is parsimonious, or broadly relevant, while using a manageable number of concepts. And 3, its plausibility in fitting with prevailing theories in the field. McGuire, 1983. Theories are also judged in the context of practitioners' and researchers' activities. Practitioners may apply the pragmatic criterion of usefulness to a theory and thus be concerned with its consistency with everyday observations. Researchers make scientific judgments of a theory's ecological validity, or the extent to which it conforms to observable reality when empirically tested. McGuire, 1983. We should test our theories iteratively in the field. Glands, K, 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches. Glands, C02.text V2, June 17, 2015, 11:10 a.m. page 35. Fitting theory to research and practice, building bridges and forging links. 35. Rosenstock, 1990, as well as in more controlled settings. When we do so, theory, research, and practice begin to converge. Researchers and practitioners of health behavior change benefit from and are challenged by the multitude of theoretical frameworks and models from the social sciences available for their use, because the best choices in direct translations may not be immediately evident. The inherent danger in a book like this is that one can begin to think that the links between theory, research, and health outcomes are easily forged. They are not. For the unprepared, the choices can be overwhelming, but for those who understand the commonalities and differences among theories of health behavior and health education, the growing knowledge base can provide a firm foundation upon which to build. We find that one of the most frequent questions students around the world ask is, what theory should I use? It is an important question, whose answer, we believe, will be found not just in the readings contained in this book, but also in the experience and judgment that equip readers to apply what is learned here, theory into practice and research. We hope that health behavior, theory, research, and practice will provide and strengthen that foundation for readers. Science is, by definition, cumulative, with periods of paradigm shifts that come more rarely as a result of crises when current theories fail to explain some phenomena. Kuhn, 1962. This applies as well to the science base that supports long-standing as well as innovative health behavior interventions. More research is needed at all points along the research continuum, more basic research to develop and test theories, more intervention research to develop and test evidence-based interventions, more implementation science research and more practice to understand and apply the processes of implementation, and more concerted attention to dissemination of evidence-based interventions. Institute of Medicine, 2002, Reimer et al., 2001, Rohrbach et al., 2006, Weinstein, 2007. Moreover, the health behavior research and practice communities are sorely in need of more rigor and precision in theory development and testing, in measures, in assessment of mediating variables, and in specification of theoretical elements, Rajewski et al., 2000. We encourage more care and attention to how theories are tested, and especially to the way variables are measured and analyzed. Building a solid, cumulative base of theory development is very difficult when one researcher's findings cannot be compared to another's. However, we also caution that while rigor is critically important in the verification of the component parts of theories and in testing hypotheses, we eschew a one-size-fits-all approach to rigor. As Potter and Green, 2012, have cautioned, the social and behavioral sciences continue to fall short in the theories and methods they bring to the systems needs identified by public health today. Many of their methods and theories have been dominated by psychology and have not dealt adequately with the broader ecological understanding of causal webs and systems interventions that we seek today. The gift of theory is that it provides the conceptual underpinnings for well-crafted research and informed practice. The scientist values research by the size of its contribution to that huge, logically articulated structure of ideas which is already, though not half built, the most glorious accomplishment of mankind. Meadowar, 1967. In this book, we aim to demystify theory and to communicate theory and theoretically inspired research alongside their implications for practice. We encourage informed criticism of Glanz, K., 2015. Health Behavior, Theory, Research, and Practice. John Wiley & Sons, Incorporated. Created from Howard on January 9, 2023, 321. Copyright 2015. John Wiley & Sons, Incorporated. All rights reserved. Trim size, 7 inches x 9.25 inches Glanz, C02.text V2, June 17, 2015, 11:10 a.m. page 36. 36 Chapter 2, Theory, Research, and Practice in Health Behavior. Theories. Only through rigorous scrutiny will theories improve. The ultimate test of these ideas and this information rests on its use over time, critical assessment, refinement, and application. The process is circular in that it doesn't end with publication of a particular study. The goal of a theory, for a small number of people, may be proof of that theory. But for most readers of this book, it will be improved health. Theory, then, is a tool for improving health outcomes. Thus, we should think about theory and practice, not theory or practice. Green, 2006, said it well. The translational gap between research and practice has long been discussed, often as a one-way street, yet practitioners to recognize and utilize the research that is being conducted. While that is important, equally important is the reverse, integrating practice-based evidence and context into the research conducted. We need a bridge between the two, not a pipeline. Achieving this vision, as would be the case for sustaining any health behavior, will require social support, supportive environments, and periodic reinforcement. The beneficiaries will be practitioners, researchers, and participants in health education programs. As this chapter and the preceding one demonstrate, health behavior is a concern of ever-increasing importance to the well-being of humankind worldwide. As scholars, researchers, and practitioners, we grapple with the complexities of human beings in populations and societies. We press forward within the limits of current methodologies while striving to build a cumulative body of knowledge in a fast-changing world. Our efforts do not always achieve successful results, but this should motivate, not deter, us in pursuing high-quality work. Continual dialogue between theory, research, and practice involves compromise, creativity, healthy criticism, appreciation of others' skills, and a willingness to cooperate, to learn, and to set high standards. We must learn to honor excellence in every socially accepted human activity, however humble the activity, and to scorn shoddiness, however exalted the activity. An excellent plumber is infinitely more admirable than an incompetent philosopher.